Thank you. My name is Bonson Miller. I'm an internal medicine physician. I'm a recent graduate of the LSU internal medicine program at Our Lady of the Lake, where I remain as one of the clinical faculty instructors. So I just want to reemphasize the importance of maintaining and stabilizing the public partnerships and how this affects graduate medical education. My experience began in 2007 when I was accepted into medical school at LSU in New Orleans. Several years later, when I was deciding on where to train and where to further my training, I interviewed at about 15 places throughout the country. I decided to continue my training at Earl K. Long in Baton Rouge because I knew my training would be just as good or better than any place in the country. About a year and a half into my residency training is when we moved to Our Lady of the Lake. It only took about 2 or 3 months to realize the benefits of that partnership, whether it's increased use of technology, subspecialty access, broader patient population to treat and learn from. The benefits were evident. Unfortunately, over the last 2 years, a lot of medical students are beginning to shy away from the residency programs in Louisiana. These are some of the best and brightest students. They're going to continue to further their training in places like Birmingham and Jackson, Mississippi, because of the uncertainty of the public-private partnerships. When you sign up for a residency, you're really committing 3 to 5 years of your training. These students do not want to commit to a place that they have no idea if they're going to actually have a hospital to train in or patients to take care of. This is extremely important because most residents, where they train is where they practice. The majority of residency programs, the students that go to those programs are going to stay in that state and train. The program in Baton Rouge is unique. About 70% of the internal medicine residents in Baton Rouge stay in the state of Louisiana. So this would really be alarming to everyone in this room. The residents in this state are the future of healthcare in this state. So by funding the partnerships and stabilizing these partnerships, we're really investing in the future of healthcare in Louisiana, and we're actually investing in the health of all of us in this room. The residents of today will be taking care of all of us in this room, and they're going to be the future physicians of this state. Chances are, if you go to a physician now, the physician that's taking care of you is a product of this state health system and the training environment created. So again, I think it reemphasizes the importance, how we need to invest and take care of this public-private partnership and preserve the training for the future physicians in Louisiana. Thank you.
Thank you. Yes, ma'am.
Hi, I'm Katie Hannessy. I'm one of the LSU general surgery residents, finally in my last year. I want to thank you guys for the opportunity to kind of share what my experience has been over the last 9 years. Wow. And just thank you for everything that you do. I'm very proud of my medical education. I was born and raised in Bossier, Shreveport, Louisiana. I went to medical school in Shreveport, and now I'm in my 5th year of general surgery residency here at LSU. The education we receive is pretty unparalleled across the country. What's so unique about it is we get an academic situation in New Orleans, we get to experience private care here in Baton Rouge, and we get rural surgery in Lafayette, Louisiana. This variability has been invaluable to my education, and the opportunity to serve underserved populations across the state is pivotal to preparing a new generation of competent and compassionate physicians. During my 2nd year was actually when we had the transition from the charity health system at Earl K. Long to Our Lady of the Lake. Not only did this enrich my education, the patient care was above and beyond what we had ever been able to do before. This is both because of the facilities and because we had now access to a large group of physicians we didn't have access to before. The good thing about our system now is that several of the physicians that we work with actually are graduates of the LSU General Surgery program. And above and beyond that, 60 to 70% of general surgeons in Louisiana have been trained either in Shreveport or New Orleans. That's huge. By cutting back that number of people that could potentially be trained in our programs, we could be putting our potential future healthcare at risk, just like you said. I want to thank you for currently continuing this relationship we have. We're very, very grateful for that. But there are, as has already been said, some concerns about medical education in the future. We've lost several students to out-of-state programs. Currently, we have over 280 residents that rotate through Our Lady of the Lake. Losing this would be detrimental not only to the general surgery program, but also other programs. I will tell you that when you think about the healthcare that you want in the future, just as been said, just make sure that you keep in perspective that these are the people that will be taking care of you one day. But beyond that, also what's important is patient care. So what's going to happen to these patients? I'll tell you, across all of the general surgery and other clinics at our lake, we saw 52,000 patients last year. That's huge. Primary care role. What does that do? Is it keeps patients out of the ER, okay, which is much more expensive. The other thing I want to tell you, I got to take care of a 22-year-old female last couple weeks. She's a 22-year-old student at LSU. She works 2 jobs already to pay for all of her education. She delayed coming to to get care for months because she was concerned about the cost. Finally, she went. She was able to be plugged into our unit, and we've been able to take care of her what's reasonable for her. She is helping to contribute to her care, but she can afford it. Turns out this little girl has synovial sarcoma, which is something very serious. But because she came to us, because of our system, we can work with her. We can work with our surgical oncologist, who she would not have had access to in the old system. This is a guy who takes all private patients. But with this system, we're able to take excellent care of her. And she's actually, we have a chance for curing her cancer, which was not have been the case before. Other than that, I just want to say thank you for your time, and just thank you for continuing to allow our education to undergo at Our Lady of the Lake.
Thank you. We have one Representative Smith for a question.
Thank you, Mr. Chairman. And I guess you're here to be thankful that the cut was not as great as it was, because you're only getting a 3% cut compared to the others. So I realize that, that's a cut, and nobody wants to be cut. But in these times, everything looks like it's going to be taking a hit. So you're here to thank us for it only being 3%, or to say you want 100%?
To thank you. First and foremost, to say thank you.
Yeah.
And just to say, I think y'all have heard from the finance people, the DHH folks, and Commissioner Darden and his staff about what they've been able to do. I think a week ago they were here. But obviously, yes, y'all have made tremendous progress, and it's much better than where it was in the beginning.
Right.
So we appreciate that and look forward to continued dialogue.
And I've had my experiences both at the lake with an individual with no care, no insurance, and then myself being there as well in the emergency room. So I've seen both sides of the issue, and understand there are a lot of folks that come through that facility, an awful lot. So thank you for what you do.
Thank you.
Representative Bacala for a question.
Thank you, Mr. Chairman. Senator, how you doing?
Good.
Good morning. Again, I'm trying to educate myself, and I know just enough to be dangerous. Other states, in my understanding, and I know that for years Louisiana was way ahead of other states, that I think we were the only state in the union that had the Earl K. Long's, the charity hospital system. So we were providing health care to the needy when others weren't. And then we got out of that, we went to the public-private partnerships. But it's my understanding today, and correct me if I'm wrong, please, but we're the only state in the country that has public-private partnerships. And I'm just wondering, how do other states do it?
It's from my experience, Representative Bacala, is that we were traditionally the only state in the nation that had a state-run, state-operated charity hospital system, and that charity hospital system was responsible for, thousands of state employees and infrastructure and buildings and bricks and mortar. Many states have hospital service districts where you pay a millage or something at the local or regional level that funds your regional hospital. They pay it through a sales tax, they pay it through a property tax, so that's how some states operate. We were looking at obviously a variety of models, but this was sort of the quickest solution that could be brought together when the state was faced with what do we do with the Earl K. Long facility here in Baton Rouge. So as I mentioned, the partnership with the lake was the first partnership, and all the other ones ensued from there. you know, I'm not to say this is the absolute save-all, end-all model, but it was the model that we came up with, as opposed to what other states have in the form of a hospital service district, which I'm sure would have to be something that be brought to the voters in a particular region, whether they wanted to assess themselves either a sales tax or a property tax to fund a hospital in their particular area.
Well, I know that in the parish that I'm from, they had 2 hospital service districts, and they existed probably from the 70s. Actually, one of them went under because a private hospital came in and basically just took all the business from the hospital district hospitals. We went out of business because it couldn't compete with the private. But and we still have a hospital service district. But again, we kind of doing things, and I think when we had the charity hospital system, we did things better. And I'm just, you know, I'm just curious how everybody else is doing it. So basically, what we're doing at a state level, at least your best understanding, is being done on a local level in 49 other states.
That's my appreciation of how most other states run their public hospitals.
Right.
It's
Okay.
through some sort of a hospital service district and a local.
And I know that doesn't apply to the training, so I'm trying to separate the two
Right.
out. And the lake is my hospital. I love you guys, and I'd hate to visit you. All right? You know, when the doctors say it doesn't hurt, I think we ought to make a law. Don't ever tell anybody. It always hurts when you say that. But anyway, okay, Senator. Well, I appreciate it. One more thing on if you can you speak for the lake, or hospitals in general? They tell me that, you know, every time I go to the hospital, you get my bill comes in, and I pay it. All right. But my understanding is roughly 50% never is paid. So you have large
Write-off.
uncollected debt out there.
Maybe these guys can address it, but you know, it's my understanding is that when you have what you call your billed charges or usual and customary charges, each facility has a contract. So if they have a contract with Blue Cross, if Blue Cross is your provider, Blue Cross has negotiated with that particular facility to pay them X amount of dollars for this diagnosis based on a ICT 10 code, I guess now.
9.
ICD-9 code. So their contract with Blue Cross says that Blue Cross will pay them this amount of money. So they may charge $1,000, but the contractual obligation between them and Blue Cross is a write down or a write off of a few $100s. I don't know if y'all want to address that more specifically, but so they do have a large, inordinate amount of write-offs just on contractual arrangements, but also based on the other payers that are out there. And then if they have a copay, if the patient has a copay, if they're a Medicare patient, for example, and Medicare covers 80% of that $1,000 charge, the patient is responsible for the 20% copay. Well, a large part of that 20% copay goes uncollected as well, because a lot of these people, they can't afford the 20%, and the provider is required to, I think, bill them 3 times and then maybe get a financial assessment on file. Then they can write off that 20% copay if the patient can't pay. You want to weigh in?
I don't know about that part. I just do the medicine.
Yeah.
Hopefully by next year I'll pick it up.
Same here.
Well, actually, when in talking to the guys, I'm just exploring, you know, where sources may be and how the state could help you guys. And I'm not talking about the Medicaid. I'm talking about the insurance after they've paid. And I know that Blue Cross will negotiate rates and fees, to make the lake a Blue Cross provider. But beyond that, the co-pays or the things that I, as a person, am responsible for after my insurance is paid. As an insured patient, I'm told that 50% of the insured patients never pay their portion of the bill when they leave the lake. I'm just curious, can we help you? I mean, that's part of making you guys a sound hospital. That's a conversation for another day. I appreciate it, Senator. Thank you, Mr. Chair.
Thank you.
Representative Miller for a question.
Thank you, Mr. Chairman. Dr. Miller?
Yes, sir.
I like your name. Miller. I have a question. You said you went to like 15 different interviews, and you said you visited Birmingham. We're the last state with the charity system. I think Representative Bacala just mentioned. As far as the medical aspect, what is the framework from the colleges in other states? Meaning, why aren't we doing training in these private hospitals? Why is it all in the public-private system? So like we're held hostage. If we get rid of this system, we don't have anywhere for our residents to go. Why aren't they practicing in a private system also?
I'm not sure. That's above my pay grade. I didn't design this. I didn't design these systems, but I will say they are critical to preserving medical education. And like I said earlier, when you sign up, when you leave medical school, and you interview and you look for a residency place to train, that's at least 3 to 5 years of your career. Really, the most important part of your career from a training perspective. So people want stability, and people want to go places that have been doing it for a long time and have been doing it well for a long time. And unfortunately, we do not have that right now. So, unfortunately, it has scared a few students off really every year from our individual programs, from internal medicine or general surgery. And these are some of these students are in the top of their medicals class, students who we'd like to keep in Louisiana.
No, I agree. We definitely would like to keep them, but would you know,
Definitely.
like a state like Birmingham,
Yeah.
their medical school do they practice in private hospitals?
So I know I can only speak for, at least in Birmingham, whether you have insurance, do not have insurance, UAB is a giant tertiary referral medical center. So in a way, it may be public-private, but no matter your funding status, you go to UAB. They draw patients from several surrounding states. So it's really a fertile ground for training. That's
an
about all I
academic
can
center.
speak.
You
on
think it
that.
would be hard for a school like LSU to start working with these other hospitals to become teaching facilities?
Not at all. I think that's already been done. LSU working with Our Lady of the Lake, LSU working with a hospital in Lafayette. So some of that's already being done.
But the one they're saying Tulane, but the one in Lafayette is the public-private partnership, right?
Right.
WUMC.
Right.
Correct. So LSU residents there will train at UMC Hospital and at Lafayette General.
Yeah, I just
which
think
is
we
the
should maybe
local.
broaden our area of where we're going to do training so
Mhm.
guys like ours aren't faced with a vote to where if a hospital is forced to close, that you guys don't have somewhere to train.
I agree. And some of the training has to take place in smaller areas, especially when you're working with LSU faculty members or teaching faculty. It's nice to have that clinical environment where you're in the same area, same hospital, instead of the same resident traveling to 5 or 6 hospitals throughout their residency. That can really cause some of the medical education part to suffer.
Thank you, Mr. Chairman.
Yeah, thank you.
Representative Bayard for a question.
Since Misha, let me ask you a question. Last year, we did a resolution, concurrent resolution, House and Senate, pertaining to putting some type of a fee on the private hospitals, or they were able to assess a fee, and they were going to be able to do some of the matching with the expansion of Medicaid. Do you have any word about that anymore?
I think that may be Cleckley's,
Yeah.
Speaker Cleckley's. I believe there's something going through the process this session, actually, that is going to allow that to be put in place. Is that, Mr. Chairman?
The speaker, Speaker Barra has a resolution as well.
Okay, he took it from them? That's what
Correct.
it's about?
Yes.
Okay, all right, thank you.
Thank you.
All right, the board is clear.